Right now, hundreds of millions of people are living with a critical failure in their body's internal energy grid. If we look at this map of a healthy biological pathway, we see the intended flow of energy. Ingested food breaks down into glucose, which triggers the pancreas to release insulin. This hormone binds to specific receptors on your cells, allowing them to actively absorb that glucose and convert it into fuel. But in a state of insulin resistance, those cellular receptors become rigid. They reject the insulin signal. As you can see happening here, both the glucose and the insulin particles have nowhere to go, multiplying rapidly and creating a massive bottleneck directly in the bloodstream. This chronic biological traffic jam is what we call high blood sugar. Left unchecked, these excess glucose molecules become toxic. Over time, they chemically scrape and degrade surrounding blood vessels, causing progressive damage to the kidneys, the eyes, and the heart.
When dietary adjustments and lifestyle changes fail to clear this backup, physicians must intervene. They deploy highly specific pharmacological tools to force the system back into balance. When foundational therapies like Metformin are no longer enough, doctors often escalate to a class of drugs called sulfonylureas. One of the most common is glipizide. It takes an aggressive approach right at the source, the pancreas. Here is glipizide's exact mechanism of action. The compound chemically binds to the pancreatic beta cells, manually triggering the release of a massive surge of insulin. And it does this blindly, whether the patient has just eaten a large meal or hasn't eaten a thing. Because of that brute force mechanism, the dosing rules are strict. Patients typically start at 5 to 10 milligrams, capping out at a maximum of 40 milligrams daily. Crucially, the pill must be taken exactly 30 minutes before a meal to properly coordinate the forced insulin surge with the arrival of glucose. If that timing is off, the primary danger of the drug kicks in: severe hypoglycemia. If a patient takes their dose but skips a meal or engages in heavy, unexpected exercise, the forced insulin strips the remaining glucose from their blood, causing a dangerous and rapid crash. Glipizide is effective at making a sluggish pancreas work harder, yet because it is entirely chemical and lacks any biological awareness of the patient's actual food intake, avoiding a systemic crash requires extreme behavioral precision from the patient. There is an alternative, more indirect method for regulating blood sugar. Sitagliptin belongs to a drug class known as DPP-4 inhibitors. Instead of targeting the pancreas directly, it goes to work in the gut. To understand how it works, we have to look at this secondary biological pathway. When you eat, intestinal tissue releases incretin hormones like GLP-1, signaling the pancreas to produce insulin. Normally, DPP-4 enzymes destroy these hormones. Sitagliptin neutralizes DPP-4, allowing GLP-1 to survive and amplify the natural insulin response. This targeted action simplifies the standard dosage to 100 milligrams once daily, which can be taken with or without food. However, because the kidneys process and clear the drug, patients with moderate to severe renal impairment must follow a strictly reduced dosing schedule. Because sitagliptin relies on the body's natural incretin response, which only activates when food is eaten, it is entirely glucose-dependent. It amplifies the existing system rather than blindly forcing insulin production, resulting in a much lower inherent risk of a hypoglycemic crash. Manipulating the human endocrine system always carries systemic risk. Both of these drug classes come with severe clinical warnings that dictate exactly who can safely take them. For sitagliptin, post-marketing reports have identified rare but severe risks. These include acute pancreatitis, which can sometimes be hemorrhagic, along with severe hypersensitivity reactions like anaphylaxis and exfoliative skin conditions. Glipizide, meanwhile, carries a major warning of its own. Based on long-term clinical trials, the FDA requires a specific alert regarding an increased risk of cardiovascular mortality compared to treatment with diet alone. This matrix shows how these risks complicate treatment for pregnant women. Sulfonylureas like glipizide can cause prolonged, severe hypoglycemia in newborns, so the drug must be discontinued well before delivery. Instead, injected insulin becomes the preferred option to maintain blood sugar levels safely. Prescribing these medications requires a complex clinical balancing act. Physicians must constantly weigh a patient's kidney function, cardiovascular health, and pregnancy status against the immediate, destructive dangers of leaving high blood sugar uncontrolled. This is exactly why the medical community defines these medications strictly as adjunctive therapy.
They are designed to act as specific additions to diet and exercise, not as convenient substitutes for dietary restraint. The absolute baseline requirements for managing type 2 diabetes remain physical. Caloric or risk reduction are the primary tools required to bring the biology back online. To verify that these efforts are working, patients have to continuously track their biology. This means daily blood glucose monitoring, along with clinical tests like the one represented here, measuring glycosylated hemoglobin, or HbA1c, to track the long-term effectiveness of the treatment over several months. Even with perfect adherence, doctors monitor for a phenomenon known as secondary failure. Over time, as the severity of diabetes naturally progresses, patients may lose their biological responsiveness to oral drugs, eventually requiring a transition to injected insulin. Type 2 diabetes represents a complex, progressive breakdown of the body's energy systems, but the strategic use of pharmacological tools, paired with consistent lifestyle management, gives patients a way to bypass these failures and keep their metabolic pathways functioning as they should.